Welcome to the FASN Kidney Week podcast, exploring the latest advancements, research, and innovations shaping the future of kidney care. Tune in for expert conversations, clinical insights, and highlights from FASN Kidney Week 2024, a go-to source for staying informed and inspired.
Good morning, good afternoon, or good evening, depending on whatever time you are listening to. This is the American Society of Nephrology Kidney Week podcast, where we talk about the fun things that are going and educational things that are going on during the Kidney Week. My name is Swapnil Hiremath. I'm a nephrologist and a professor of medicine at the University of Ottawa in Canada.
Hi everyone, my name is Hiddo Heerspink. I'm a professor of clinical trials and I'm based at the University Medical Center Groningen in the Netherlands.
And I'm Meg Jardine and I'm a trialist from the University of Sydney in Australia.
I really love the location actually. Sunny San Diego is the best place to have a Kidney Week. I wish they did Kidney Week in San Diego every year, right? It's such a nice location.
I couldn't
Great
agree
weather.
More. Fantastic, so nice weather here.
Yeah. But I think one of the innovations that this Kidney Week has had is the late-breaking trial session. So typically, the FASN started having the late-breaking sessions just over 10, 15 years ago, but it used to be just one session, the high-impact trial session. This year, as people who have attended have noticed, we had 4 sessions. We had 2 in the morning and 2 in the afternoon. Do you want to say something about the process that led to that, Meg?
Well, just briefly, because there's so much science to talk about as well, but I think the late-breaking space has got very competitive. Mm-hmm. All the big conferences are really competing for the wonderful trials that are coming out in kidney disease. We've got so much activity now. And so there was feedback from the community, and the FASN has responded, has broadened out to 4 sessions, as you say. Some of the talks are getting more time. There have been discussants with some of them, which has provided some really useful context. I find that's really good too. If you're getting something from out of area, it's really good to have that framing. But the other thing is the questions, which it can come directly from the audience, and you can upvote the questions that you like. So I think that's helping the moderators see what's really hitting with the audience, where the unmet questions are. So it's been an interesting change, but I think it's been a productive one.
Yeah, it has been, and you're absolutely right about the increase in the number of trials, right? I think there used to be observation. Remember the days of large database studies and some small trials that used to be negative. There are such a large number of trials being done and published. I was just keeping account of the simultaneous publications, and we are now up to 13 so far. We are on, this is still Saturday afternoon that we are recording, and there have been 13 simultaneous publications already, and I think there'll be some more coming later today. So this is phenomenal. It used to be like maybe we would be lucky to have 1 or 2 papers being published. So I feel like a cardiologist, right? We are having so many papers being published in high impact journals.
Yeah, it's a kidney renaissance.
It is truly a kidney renaissance.
And the nice thing is that you also see clinical trials that are originally designed for cardiovascular endpoints, and the kidney endpoints become important secondary endpoints, and they are reported here. So you see that cardio-kidney interaction also more and more here at the Kidney Week.
Exactly right. We had the Fine Hearts study yesterday, the Fine Hearts HF, which was the cardiovascular study with finerenone in heart failure, and they presented the main outcomes a few weeks ago. But kidney is a big part of the heart. It's the kidney metabolic syndrome now, as the American Heart Association calls it. So we had the kidney outcomes specifically presented yesterday, which show that yes, if you look at the renal composite endpoints, there was not much of a difference. But we look at new albuminuria or increase in albuminuria, finerenone seem to have an effect there, which is a very interesting finding. Again, it's not surprising. We know what mineralocorticoid antagonists do, but to see that in this HFpEF, HFmEF low-risk kidney patients it's a very interesting finding.
Oh, and I think that's what the secondary outcomes give you. It's very unlikely we'll ever get a trial specifically designed to look at low-risk kidney patients for kidney outcomes. But of course, when you pick up these secondary analyses from other trials, and it does help practice. We did see with a low-risk population with very little progression in the placebo group, you don't see the benefits on EGFR that you would for a high-risk group. That might seem obvious, but it's important to have it confirmed so that when you know for the patient in front of you, what's the trial evidence?
Exactly. Yeah.
But we did see a lot of secondary analyses reported here. I think we had 3 secondary analyses reported from the FLOW trial, which was at first, as we know, was presented at ERA earlier this year. And then we this Kidney Week we saw Kathy Tuttle presented the EGFR and the albuminuria subgroup analyses. We saw reports on the infectious outcomes, and we saw the subgroups for mortality.
Yeah, and we also saw there was also a couple of papers from Convince, the hemodiafiltration trials, where they presented they presented a meta-analysis of the pooled HDF trials, as well as they presented some quality of life data from the Convince trial. So these are again really important large trials, and there's always more information that we can glean from those trials, and this is an opportunity to highlight those kind of findings.
One of the trials that was, in my view, really interesting was the EMPA-Kidney trial and the long-term follow-up of EMPA-Kidney. EMPA-Kidney demonstrated that empagliflozin in patients with chronic kidney disease with or without diabetes reduced the primary endpoint, kidney endpoint, by 28%. And in contrast to all the other SGLT2 trials, patients were followed in an observational analysis over 2 years. And 43% of patients were using, during the follow-up, an SGLT2 inhibitor, and that could be any SGLT2 inhibitor. So placebo patients were transitioned to empagliflozin. Surprising finding, only 43%. You have a positive trial, and only 43% of patients are then in practice treated with an SGLT2 inhibitor. It was a bit disappointing.
Well, I thought...
Go ahead.
Well, look, just on that, I thought it was really interesting because that was a trial population. That was a group of patients and clinicians who decided to go in the trial. And maybe some of them had fallen below EGFR 20, so might not have been considered eligible from that point of view. But overall, surprisingly low, no better than the rates you get in the best real-world evidence. So to me, it said the next wave, given the really clear benefits for SGLT2s, the best wave of research has to be on how we get better uptake.
Exactly. We have to think about implementation research, right? And we develop a lot of protocols during the trial, a statistical analysis plan, a project monitoring plan, what have you. But maybe we should think about an implementation plan directly when we start a clinical trial. But going back to EMPA-Kidney, what I found interesting was the benefit that you still achieve after 1 year. So after 1 year, in the post-follow-up period, the group that originally received empagliflozin still had a significantly lower risk of the primary endpoint, almost identical, if I recall well, compared to the overall trial result. So there was no attenuation of the effect, even after a year of treatment.
Yeah, it was on some of the outcomes it was attenuating a bit.
But it was close to 30%, 24, 25%, which is like, I would not have expected it, right? The blood pressure effect is gone, the glycemic effect is gone after you stop the drug, right? But the drug is out of the system. But there seems to be something still happened.
Yeah.
Maybe, maybe the kidney protection or whatever has happened is still going on.
Yeah.
Or maybe as it came up in the Q&A, maybe they left the patients in a better shape after being 3 years on EMPA-Kidney.
Yeah, that's what I think is
sort of, again, it's hard to say exactly what that better shape means, but something improved about their protoplasm that they still did well for a year.
And we've got to remember we don't completely understand how they work. We know lots of effects on mediators, there's lots of preclinical science, but how much each of those factors matter in a clinical situation, we don't properly know. But I think what we do know is it's not just the glucose lowering or the blood pressure lowering, the effect goes beyond that. So there are some long-term...
But regardless of the effect is still present after a year in the follow-up.
Yes, but it's weakening, and it clearly weakened after that.
After 2 years, it was gone.
So the take-home for me was to truly get the clinical benefit, you've got to keep patients on the drug, which then leads back to the implementation.
It's kind of a glass half full, half empty, right? Like the effect stays for 1 year is kind of a glass half full, but beyond that the effect does not stay.
Yes.
So that's the glass half empty view of it that we really need to be on it. Which goes back to your point about implementation, right? We really need to focus not just in trying to get that 40% to 100%, but also trying to make sure that people who start on it stay on it forever. Like there are times when someone gets a UTI and it stopped and it's never restarted. Someone gets a yeast infection and instead of just treating the yeast infection, the drug gets stopped and it doesn't get restarted. So I'm sure we have a lot of work to do there. These are phenomenal drugs. Like Flozins are remarkable. I know it's like a once in a lifetime. Though of course then that's what I thought initially when SGLT2 inhibitors came. It's that like these are the statins, though statins didn't reduce kidney failure. Flozins reduce kidney failure as well. But then after that, we see GLP-1 RAs and we see MR antagonists and we see all these therapies in IgA nephropathy. I think this is, like you say, the kidney renaissance. This is really a glorious time.
When Meg and I finished Credence and when I finished DAPA-CKD, there were people telling us, you are lucky, this is a once-in-a-lifetime experience and you will never experience it again. Well, I start to doubt that, indeed. And now with the GLP-1s and the incretins, what they are doing to the kidney is at least as much as an SGLT2 inhibitor, in my view, and probably even more. You know, the SMART study that I then presented was a big surprise to me. SMART study, a clinical trial in chronic kidney disease without diabetes and patients with overweight or obesity treated with the GLP-1 receptor agonist semaglutide for 24 weeks. After 24 weeks, 52% reduction in albuminuria. Admittedly, relatively small study, short follow-up, 24 weeks, 101 participants, but still a big effect.
Yeah, look, I wouldn't undersell it at all, Hiddo. I was really excited to see it because it was a clear, dedicated kidney trial done by a world-class kidney trialist. I thought it complemented what we saw from SELECT. SELECT was semaglutide in an obese population, but it wasn't a dedicated kidney trial, and it was good to see the protection of kidneys largely based on albuminuria reduction, but not conducted with anything like the forensic rigour that you conducted this with. So I think the two together is a very comprehensive picture.
Thank you, Meg. And what I really liked about this study is the change in EGFR creatinine. You saw a decline in creatinine, modest decline in the first 8 weeks of about 1.5 mils per minute with semaglutide. And then during treatment, the EGFR goes up and is back at 0 after 24 weeks. A similar pattern that we've seen in FLOW. And then when you look at cystatin C EGFR, no change at all, a flat line in the semaglutide group. And if you look at measured GFR in the study, we measured GFR with iohexol, only at baseline in week 24, no change. So what is happening in those first weeks with creatinine, body weight, muscle mass? It leads to
it's like the opposite of the blip that we see with RAS inhibition and SGLT2 inhibitors.
Yeah, well, that's what I really like too, that you did all those different ways of measuring, because that has made the interpretation of some of the GLP-1 receptor agonist trials a little tricky. So to have that, clear exposition, same population, different ways of measuring kidney function, that was really useful.
Yeah, exactly. I still remember after FLOW, there were all this discussion about, hey, maybe it is muscle mass that's changing, and maybe, changes in fat, would that affect the cystatin C measurement? So the fact that, you could show that so clearly was a very impressive, and it's a really important thing to do.
Yeah, but we didn't present because we didn't have time to analyze all the data yet, because the study was only finished at the end of August. So we only, all the work done was in a couple of weeks. Yeah, it was hard work. We also have bioimpedance spectroscopy. So we have lean body mass and fat mass. So we're going to correlate changes in lean mass, fat mass with creatinine, cystatin C, EGFR.
That will be really interesting.
And find out what is actually happening.
Beautiful.
So on that note, since you brought it up, what's the process of, getting the lead? We all, when trials get published, presented, like even today, there were really fantastic trials that were presented, and I was like, why is none of them simultaneously published? But I think getting that simultaneous publication is a huge amount of work. So as experienced trialists, would either of you want to comment on, what that process is like? Is it, I've heard it is painful, it's very difficult. You stay up at night to get the analysis done the night before or something. Is there?
Not for a trial like this. The other factor too, though, it's partly what the trialists are doing, it's also what the journals do. So if you don't get your first journal that you approach lined up and accepting it, then
you're done. There is not enough time to resubmit it before the...
Looking at the process, I was speaking to journal editors already in April.
Okay.
So you talk about, when you finish your trial roughly, and you talk about the trial with the journal editors, and you ask the journal editors, when do you need the publication for a full peer review, and how many weeks do you require from peer review to online publication? So then you count back and you know when you have to submit your trial results to the journal. And it's a process where you collaborate and work together with the journal editors. Mm-hmm. And it's a one shot often.
Yes.
And because if the reviewers or the editors don't accept the publication, then you're too late.
You're too late. Exactly right. Yeah. There's no opportunity to resubmit before the presentation deadline comes.
Could I change tack a little bit?
Yeah.
The other big group of trials that I think we saw presented with all the health service, the delivery of healthcare trials, and perhaps because we had more late breakers over the conference, we saw quite a few. There was the CAT AKI from the Perry group. There was the pain, the intrusiveness of pain trial that Laura Denver presented. There was one on the management of hyponatremia, my apologies. I thought all of them, I felt the standard of those trials is really lifting.
Yeah.
It was much more nuanced. I thought they'd anticipated in their design, they'd anticipated a lot of the barriers, they'd collected the process markers. So I did feel that, not all published, we'll always wait for the publications, but I did feel at the end of the presentations that I had a good understanding of, if it succeeded, great. If it hadn't succeeded, whether it was because of the delivery or whether it was because the intervention just wasn't the right intervention for the condition. So I thought the science there has really been advancing, at least in the kidney
Exactly
world.
right. So for the hyponatremia trial, they did show that the targeted, approach increased the sodium number. So what, right? So they measured the clinical outcomes and they show that increasing the number doesn't actually change the outcome. And similarly for the AKI trial, where they showed that, hey, their intervention really changed the processes. The recommendations were followed way higher. So it's not like the Perry Wilson's group's earlier alerts where people were alerted but they didn't do anything on that.
Yes.
They didn't act on that. In this case, they did act on it, but despite the action, despite fixing the volume status, say, or stopping the nephrotoxic medication, AKI did not go down.
So I thought that really...
What is the explanation? Do you think that the follow-up was too short in that AKI trial?
That's the beauty of AKI. It's a very quick turnaround.
Yeah.
To me, they'd had earlier trials where they'd showed heterogeneous effects in hospitals. Didn't see that at all this time. They did achieve everything you would think you should achieve in clinical medicine
outcomes,
to at least get a separation.
Yeah.
So the take home for me is it's not going to be enough to badger people to do what they should. We're not going to reduce AKI.
Yeah.
I suspect we're just recognising too late. So we need better diagnostics to pick up the insult earlier on, and maybe we need other treatments, but we need something disruptive in that space.
Exactly right. And the assumption, of course, is that with these alerts is that maybe the bedside clinicians are missing that they haven't stopped the nephrotoxic agent because they have missed it. Maybe the real nephrotoxic agents they have realized and they have stopped, and we are picking up the the milder cases where it doesn't matter. Like we are saying, maybe these clinicians are not smart enough. That's why they need the help. Maybe they have already done the right things, right? It's likely, it's possible that what you say is true. We need to do things early, but I'm not sure. Like maybe the interventions don't matter.
I thought, the advantage is that because it's a hospital-wide approach, it's not like they're selecting out patients who might have milder forms. They're presumably picking up everyone. And there was enough separation between the groups so that, it's never going to be perfect. You're always going to get some good behaviour in the control group. But there was enough separation and yet no impact on the outcome. So to me it says that intervention is just not going to be enough.
Exactly.
Yeah.
But it kind of is it brings up the other thing about, things we are... in some places, we are able to improve outcomes so much, especially I think in the space of diabetic nephropathy where, yes, we had the RAS inhibitors, now we got the fluorescents, now we have got the GLP-1 RAs, maybe the non-steroidal MRAs. Now we are at such a good place. It's no longer like, kidney failure happens so quickly. How are we going to show benefit for the next new drug that comes in, which will have to have the standard of care is going to be all these things. And the GFR progression is going to be so slow now, presumably, it'll be hard for new agents to break through.
I don't know, to be honest, because there are patients who have very high albuminuria levels, and you get them down by 30%. But if you are then having reduced albuminuria by 30%, then you are at a level of albuminuria that carries the same risk as an untreated patient that started at that level. So suppose you have a patient with a proteinuria level, let's say high, diabetic kidney disease, 2 grams per day. You reduce it with SGLT2 by 30% down to 1.4. You reduce it by 30% down to 1 with a GLP-1. Then you're still at 1.
Yes.
And you're still at risk of an untreated patient only with RAS inhibitors of 1.
Right.
So you need to get it really down. I realize that there are fewer patients with all these new medications that are at 2, because all these patients, you shift the distribution to lower levels.
Yeah.
But we just finished recruitment of a clinical trial, 1,500 patients, proteinuria more than 1 gram per day, 1,500 recruited in 8 months.
Wow.
When we started 8 months ago, people told me, you'll never find these patients. They don't exist anymore. 1,500 in 8 months. So they are there. They are willing to participate in clinical trials. So our work is not yet finished.
Yeah, our work is definitely not finished. But your presentation on the innovative trial designs, I guess that will also be valuable here when answers are hard to find. We can use those kind of trial design, like for example the win ratios or the N-of-1 trials. Those kind of things may become even more important for us to understand. I still have to get my head around to understanding those win ratios, but those kind of things make so much more sense, right? To get answers faster, but also in these kind of situations where you may not have enough events, in the clean events of kidney failure, then you can use these kind of methods.
Definitely. Yeah. Maybe for the listeners, there are new developments in endpoints and how we assess clinical endpoints together with GFR decline. And this is an area that is already implemented in cardiology, and we're now carrying that over to nephrology to assess drug effects on a combination of GFR slope and clinical endpoints, because the current endpoints only include clinical endpoints that are only reached by a fraction of patients, but we would like to assess the drug effect in everyone, and with eGFR slope you can assess the drug effect in everyone.
And I think things like the N-of-1 trials, it's a good thing to bring up, because some of the situations they're used for is more the implementation and the precision medicine, the individual patient, what is the drug that suits them. We've been speaking about it for a while. We've not really had the opportunity to practice that in nephrology because we don't have a broad spectrum of therapies, but now we do.
Now we do.
So we will again need to be a little bit disruptive if we're things that are in the post indication space, how you find funders for that, how you find resourcing, but certainly areas where those trials have been used, like statin-related myopathies, they've been effective. So we may be moving into an era now of more precision medicine for kidney disease, and these might be the trial designs that help us find suitable pathways. But we do need something, because even with the wonderful results from the SGLT2s and now the GLP-1s, we are still seeing that uptake and adherence in clinical practice is nothing like what we see in the trials. And partly maybe that's education and everything else, but maybe there's a precision question there. People might be stopping the drugs for good reasons. We're not going to find that out if we're not researching in that area.
Yeah, and it may not be just education, right? I think there's no reason why we shouldn't be doing implementation trials to see what are the implementation methods to get increased adherence there, rather than just education. Education is the easy way out, but it rarely works. So I think we need definitely more efforts and implementation. Going back to our discussion on the EMPA kidney.
Yeah, absolutely.
So it's really a renaissance in nephrology. I still remember the old days when we would come here and it would be so depressing, where we would have a few negative trials, a few observational database studies. This is just a wonderful time to be in nephrology, to see the energy, the enthusiasm, the hope it's really fascinating time, and Kidney Week has really brought that to the fore.
Yeah, absolutely. And for the young nephrologists, it's really time to help us in the fight against kidney disease and be part of this
we should
community.
be redefining the standards,
Yeah.
as Dr. Cruz said at her presidential address.
Yeah.
Yes, and I think at the centre for it all is the participants and the patients, and that's another thing we've seen in all these presentations. A much greater role is emerging
Of the patient
for the
participation.
patient partners. Yeah. So I think we've all had a great conference. Less than a day to go, but it's been really exciting, and looking forward to next year's already.
Thanks for tuning in to the ASN Kidney Week podcast. Stay connected for more updates, insights, and expert discussions on the future of kidney care. Be sure to follow us on social media to help create a world without kidney diseases.